So each year we bestow the Naiman-Vickars Professorship on a leading clinician scientist who emulates the philosophies of these two hematologists. Shelley Naiman and Linda Vickars were a husband and wife team of physicians who changed the face of hematology in Vancouver, British Columbia, as well as in Canada. Shelley grew up in Toronto, completed his medical training in Los Angeles, and joined UBC in 1968, where he became a leading figure in the university's hematology community for more than 30 years. After introducing several advanced concepts to study bleeding and clotting disorders at Vancouver General Hospital, he became the founding head of the Division of Clinical Hematology in the Department of Medicine. He established the first bone marrow transplant center at VGH, and later became the head of the hematology lab at St. Paul's Hospital, where he created the first clinic for hemophilia. Linda Vickars was born and raised in BC, trained at UBC as an internist and hematologist. At St. Paul's Hospital, she built a world-class comprehensive program in hemophilia and bleeding disorders, as well as an equally excellent program in hemoglobinopathies and red cell disorders. Under her direction, both of these programs became recognized internationally. Both Shelley and Linda were widely regarded as superb clinicians and teachers and were keen advocates of promoting science. They were regular attendees at this symposium and awed by Earl's accomplishments. In their efforts to promote excellence in teaching, education, and research that bridged the gap between the lab and the clinic, they were active members of the Center for Blood Research. Their contributions provided most of the travel awards for our visiting trainees from across Canada and the States, and they also established this professorship in their name. So it's my pleasure to introduce Phil Wells. Dr. Phil Wells is this year's recipient of the Sheldon Naiman and Linda Vickars Professorship in benign, and as actually Linda used to say, it is nothing, there's nothing benign about it. That's why I scratched that out. And I think it's more commonly now called classic hematology. But Phil entirely fulfills everything that Linda and Shelley held close to their hearts. A passion for teaching and training, research and excellence in patient care. Phil Wells is a hematologist with a master's degree in epidemiology and specific expertise in venous thromboembolism, having held the CRC and University of Ottawa distinguished research chairs in this area. He's obtained many millions of dollars as a principal investigator or investigator from peer-reviewed agencies and has published over 450 peer-reviewed publications in leading journals. His main research interests have been in the area of diagnosis of deep vein thrombosis and pulmonary embolism and the development of predictive algorithms. The Wells model, or Wells score, named after Phil Wells, for DVT and for PE are taught in medical schools and used worldwide. He's been the division chief in hematology and the chair of the Department of Medicine at the University of Ottawa, but currently works on research and clinical care in the world's most comprehensive and research-intensive thrombosis unit at the University of Ottawa. Please join me in welcoming Phil.
Thanks so much. It's such a great honor. Shelley and Linda were really such treasured colleagues and superb physicians. And when I was asked to give this presentation, I didn't hesitate for a second. It's such an honor to be here. So I realized, as I've been meeting people in the audience and other speakers here, that not everybody is a venous thromboembolism expert or venous thromboembolism clinician. So I probably should have had some more introductory slides. So before I talk about two kind of weird topics within my area, I just want to give a little bit of background for those who don't really know a lot about venous thromboembolic disease. So it is a very common problem. So it happens in 2 to 5% of people over the course of their life. It does result in death in a significant number of people and a high degree of morbidity. It's basically, we're talking about people who develop clots within their deep venous system, predominantly is what we're going to talk about today. And clots, when we go to patients, we tell them they have blood clots, they think it's a small clot like the size of your fingernail. But of course, when you develop a clot in your leg, we're talking about clots that are like this long, or in my case, this long. And those things can be very dangerous, of course, because they can travel up to your lung, and that's called a pulmonary embolism. Well, it's pretty obvious that if you have a great big one up in your lungs and you're short of breath and you have a lot of symptoms, that you better get that treated. But what's not so clear is what do you do when it's a little tiny one? So that's what the first topic will be about. And at this point in my career, as I'm fading out, I really have almost no disclosures. So is isolated subsegmental PE really a 21st century diagnosis? I think it probably is to some extent, but let's just make sure we're all agreement in the definition. So basically, what we're talking about is a clot confined to a very small vessel within your lungs. There's about 263 branches of blood vessels in your lungs, and the smallest ones are called subsegmental vessels. It's important that we distinguish between whether they're single, so SSS PEs, or multiple subsegmental PEs, and that'll become a little relevant as I go through this. So in the land before time, which is when I trained, contrast pulmonary angiography was the gold standard. This was a test when you had a catheter inserted in your groin. They passed it up to your lungs. They squirted dye. It was an invasive procedure. The radiologists hated doing it. We had to beg them, get down on our hands and knees to ask them to do it. So when ventilation perfusion scanning was developed, people rapidly adopted that. But no one really liked VQ scans. I don't have a picture of them, but they're not very anatomical. They're difficult to interpret. There's a whole bunch of criteria as to whether it's a low probability, intermediate, high probability, and so on. So it drove people crazy. So in 1998, when computed tomographic pulmonary angiography was introduced, people embraced that big time because you get an anatomical picture of your lungs, which is intuitively something that we all prefer. And with that invention, the CT pulmonary angiography rose 14-fold in use over a 7-year period in the early 2000s. And of course, VQ scanning went down. But you'll see VQ scanning went down by 52%, way less than angiography went up. So people really ordered this test a lot and still do today, and that's a bit of a problem. It's become even more of an issue because now you can do very small imaging, very small vessels, and in fact you can detect clots that are 1 to 3 millimeters in diameter. And you have to think that that goes back to those little fingernail ones I was talking about. Maybe they're not so important. So what happened over this time frame in the early 2000s? You can see in the large black, to the left in the histogram, the large black bars are the rates of post-operative CTs being performed. Dramatic increase over that time because the test was available and it was easy to look at. And there was an increase in the number of pulmonary emboli, which is the second set of blocks that are moving up. But there was no change in death from pulmonary emboli. So a lot of these scans perhaps were maybe not necessary. And if you look at the graph on the right-hand side, you'll see in the triangles, those represent subsegmental Ps diagnosed per 1,000 surgeries, and they went up dramatically, as did segmental, which are also somewhat small clots. So perhaps an overdiagnosis situation was coming about. And if we look in the 90s, when there was the fundamental study comparing this invasive contrast angiography to VQ scanning, high probability scans rarely had subsegmental clots. Only 1 out of 148 cases in this analysis was a subsegmental clot giving you a high probability of PE. So most people who we called PE, because they were high probabilities predominantly, did not have little tiny clots. And if you look at those who are low probability, you'll see that 17%, 10 out of 59, actually had subsegmental PEs. But many of those patients weren't treated. So the question was what to do with these weird interpretations of VQ scanning to have optimal patient outcomes. So what happened was that several prospective management cohort studies were performed, and that demonstrated that patients who had low or intermediate VQ scan results could be safely managed without anticoagulation by combining that result with ultrasound results and pretest probability. So then we thought, well, let's do a study, a randomized trial to compare CT scanning to VQ scan and be sure that we're still managing patients safely when we use those VQ scans because everybody has really loved and adopted the CT scans. So we published this study quite a few years back now in 2007. There are about 700 patients randomized to the CT scan and 700 randomized to the VQ scan. And PE was diagnosed in 5% more frequently in the CT patients than the VQ patients. All these patients were managed by an algorithm, and at the end of the algorithm, which involved ultrasound and sometimes serial ultrasound tests, repeating the ultrasound a week or two later, if you had no clot detected at the end of that point in time, patients were followed for outcomes. And during that follow-up, there was no difference in the number of events that occurred between the two groups. And you think, well, wow, that means did we overtreat 5% of patients? Because those 14% of VQ patients in a randomized strategy were the only ones that were treated. So that suggested that maybe you could not treat small p's, and was just further evidence that we were doing the right thing from those cohort studies that we had performed. And indeed, it's hard to actually be sure that it really is a blood clot. So in this study out of the US over 3 years at 3 hospitals, they included CT scans reporting probable or definite PE, independently reviewed them by 4 thoracic radiologists. They found that 15% of subsegmental PEs that were acted upon were actually judged to be false positive by this consensus. So it's where the false positives lie is with these little clots. And this study and others that we actually did in our center suggested this would be the case. So then the question came up, well, we better do a study to see, do we actually need to treat these? So we performed a study which interestingly took 10 years, and there were some studies before this that suggested subsegmental PE represented 20% of all PEs. So you think, well, why could we hardly recruit any patients over a 10-year period at 18 sites? So maybe it's not quite as common as we think, but regardless, so over this period of 10 years at 18 sites, we recruited these patients. We excluded very high-risk patients. We would say those are people who have active cancer. Those are people who had prior VTE, because they really should be treated anyway. Those people who were still sick and in hospital, and those people who had already had anticoagulation therapy. And all those patients were to get an ultrasound done, and if there was no DVT detected on the lower extremity ultrasound, the idea was to repeat the scan, the ultrasound scan a week later, and if it still remained negative, to not treat those patients. And so we would have a cohort of people with very small clots in their lung, no clots in their legs, who we would not treat. We hypothesized that the rate of recurrent events in the follow-up period would be 3% or less. And just to show you a little bit about some of on the table there, which you probably can't see most of, is just the pertinent boxes I put in the red squares. And you can see those that had single subsegmental PE represented about 72% of patients, and about 28% of patients had multiple of these little tiny clots. And some of these patients were on antiplatelet agents. So there were 292 patients, 18, 6.2%, and 10, 3.4% had a DVT on the initial ultrasound. So those ones are sort of out, you would treat them. And on the repeat ultrasound, we had a further number of patients, a further group of patients, 8 patients who came back with a clot. Now, all these patients were meant to be treated, but the 8 distal DVTs, 8 of the distal DVTs out of the ones that I have on this slide were not treated. So that was sort of against what we'd wanted the physicians to do in the management trial. So what happened? So the primary outcome of an event during the follow-up period of 90 days occurred in 8 patients, and so it was 3.1%. So as we publish the paper, we have to say it's a negative result. We didn't meet our expectation of less than 3%. And so people say, oh, well, we got to treat subsegmental PE. But not so fast, because I think I want to present some nuances to the results of our study and see what people think. Of course, in terms of bleeding was infrequent because most people did not receive treatment. Only those people those groups, about the 38, 48 patients that were diagnosed received treatment, so bleeding was not common. But if we break it down, the cumulative incidence of recurrent VTE was only 2.1% in the single subsegmental PEs, and it was 5.7% in those with multiple subsegmental PEs, with a hazard ratio of 2.7. That didn't reach statistical significance, but it certainly suggested that they may have different outcomes. And then what about age? So recurrent VTE by age was only 1.8% if you were less than age 65, but it was 5.5% if you were over the age of 65. Again, a fairly high hazard ratio, but due to the small numbers of patients in this study, that was also not significant. So the discussion point is this. The recurrence rates were higher than we expected, but they're still not bad. And if we treated those distal DVTs, perhaps that one extension of that distal DVT would not have happened, and then the event rate would have been 2.6%, so it would have been a positive study. So it shows you how difficult sometimes it is to rely on sample size and guesses when you're trying to figure out what's a safe objective for your study. So, and I will remind you that we did exclude patients with cancer. The other point I think is worth talking about, for those of you that are involved in this area clinically, would know that we typically use a 90-day follow-up period for evaluating whether a strategy is safe. That was picked completely randomly when I was in training in the Land Before Time. And basically it's because if you look at curves, most of the recurrences occur over a 3-month time frame. So he said, well, let's follow everybody for that 90-day period. But half of the people who got a new clot the clots happened after 48 days of follow-up. So I'd say it's pretty unlikely that was an initial miss when it's almost 2 months later when they get an event. But that's kind of the paradigm that we've adopted, and maybe that's not ideal. But even still, so what's this rate of 3.1% without treatment? Is that good or bad? So if we look at this study here, this is a meta-analysis that showed the rates of recurrent VTE on anticoagulation in patients with pulmonary emboli from studies that were done back in the 1990s and early 2000s. And you can see that the rate of recurrent VTE was actually 3.6% in that 90-day follow-up period in patients who had a pulmonary embolism. So those who were treated had the same rate of recurrence as those that we didn't treat. So maybe that rate is not so bad. Food for thought. And of course, the people who got treated in this particular meta-analysis had a risk of bleeding, and that major bleed rate was 2%. Now we mostly use DOACs, direct oral anticoagulants, instead of vitamin K antagonists. So is it any different with DOACs? And it looks like no. If you look at the studies that compared DOACs to vitamin K antagonists in patients with PE, you can see the recurrence rates were basically similar in those studies. They were not statistically different. And the numbers were similar in that they were around 3% of people recur. So when we had this information, the last time we did the chest guidelines in 2021, we said that patients with subsegmental PE and no involvement of the proximal veins, no proximal DVT, and have a low risk for recurrent VTE, we could surveil these people and not use anticoagulation. And if you're a high risk for recurrent VTE, we suggested they should be anticoagulated. What's high risk? High risk is those who have recurrent or progressive VTE if they're not anticoagulated, and that's going to be people, like I mentioned already, who we didn't include in the study. Patients who had cancer, patients who are hospitalized, have ongoing reduced mobility. So what are my recommendations on this? So first of all, you should always do an appropriate assessment. This is summarized in the bottom list. Before ordering a CT, don't order a test if you don't need it. Always review the scan with an experienced radiologist because it may be a false positive. Always get the lower limb ultrasound. Estimate bleeding and thrombosis risk. Consider other indications for anticoagulation. Consider comorbidities. So if you have a multiple subsegmental PE and the patient's at low bleeding risk, then you should probably just treat with anticoagulation. If you have multiple subsegmental PE and no DVT, but you're high risk of bleeding, you have a risk-benefit discussion with the patient, and perhaps you don't need to treat those people. If it's a single subsegmental PE and no DVT and high risk of bleeding, then definitely no anticoagulation. And if it's a single subsegmental PE and no DVT and a low risk of bleeding, then you have that conversation with the patient. You consider factors like comorbidities, cost, and patient preference. And so that's all I want to say on that topic. So I think you can tell I believe there's more work to be done in this topic. I think there should be a randomized trial to assess this sort of a management strategy, and that'll be for somebody else to do because I'm retiring in a year. Now, the other topic that we all debate a lot is extended treatment. Again, for those of you that aren't familiar with this area, for most people who get a venous thromboembolic disease, except single segmental PE, we treat for 3 months, and then we make a decision on whether we're going to continue their treatment, which we call extended treatment. So what's the principles for that? I mean, this should be obvious. You don't even have to be a physician, I think, to know what these principles should be. You've got to determine the risk of a recurrent VTE if you stop their anticoagulation, and then determine the risk reduction if you continued it. But you also want to determine the risk of bleeding with a continued treatment and compare that to their risk of bleeding if they were not on treatment. And what is that balance? And that's how you should help decide in each individual patient how you're going to manage them. But you need a lot of information to be able to do that. So we thought we were getting pretty smart, and over the 2000s, late 90s, 2000s, we came up with some principles that have been pretty widely adopted right now. And that is if you have a provoked VTE, after 3 months of anticoagulation, if it was a major transient risk factor like surgery or trauma, they have a relatively low risk of recurrence, less than 1% in many studies, maybe as high as 4%, but generally a lower risk. And so the dogma has been to not treat those patients. If you have a non-surgical but provoked risk factor involved, so medical patients, pregnant patients, patients wearing a plaster cast, the rate of recurrence is a little higher. It's kind of in a gray zone, and most people think, well, maybe we should be treating those people because they have a fairly significant risk, and it's higher than these other major transient risk factors. This came from population-based studies. And so the group left over, and I will state we're not talking cancer. Cancer's out. They're a different ball of wax. But if we're talking about unprovoked PE or VTE, that's basically VTE in the absence of all that other stuff I just mentioned. And those people, now we have been treating those people indefinitely. So that's a long time. And we've struggled with trying to determine what's their bleeding risk, how do we balance that. We haven't done a good job at it. But population-based studies suggested the unprovoked VTE should always get treated. And why? Because the overall recurrence risk was felt to be about 10% in the first year and 30% after 5 years. That's pretty high. And indeed, if you'd had a previous event, some studies suggest your risk of recurrence is 50% higher than that over a 5-year period. And of course, risk of fatality is higher if your initial event was a PE because for reasons we don't understand, you tend to recur with the same event you started out with. So if your first event was a PE, 80% of people, if they do get another blood clot, are going to have a pulmonary embolism again. If your first event was just a clot in the leg, 80% of those people are going to represent with another clot in their leg. So obviously the one in your lung is a lot worse, even though the ones in your legs can go up there, the one that presents in your lung can result in instant death and certainly more significant symptoms if you're quite air hungry, short of breath. But there are other issues we have to consider here. So gender. So it turns out that if you're a woman, your risk of thrombosis recurrence is about half or less than that of a man. So as men, so if we just take that 10% figure in unprovoked at 1 year, it's closer to like 6 or 5% in women, and it's closer to 15, 16% in men. So that's quite a different spread. So that obviously has to be something that's considered. And that gender finding is true regardless of adjusting for age, duration of treatment, and whether you have what we call a thrombophilia, which is a genetic predisposition. So does this influence the decision making? Well, it should, but we haven't done a great job at incorporating that. Now, what about more recent data? So more recent data suggests that there may be not a difference between patients who have these minor transient risk factors and the major transient risk factor of surgery. So at 24 months in this review in 2010, it was suggested there was still a difference, 7.4% in unprovoked patients, 3.3% in those with a transient risk factor, but much lower, 0.7% in those who had their risk of surgery or trauma. So that just reinforced our unprovoked and provoked classification, and that we shouldn't treat patients, you shouldn't extend treatment in patients who have had surgery as the cause of their clot. However, more recent data suggests maybe that's not so the case. So a registry with 10,000 patients in 2020 suggested there was no difference. When they compared patients with major transient risk factors, surgery, trauma, versus those with minor transient risk factors, medical illness, cast immobilization, thrombophilia, whatever, they found the rate of recurrent VTE adjusted hazard ratio was 0.99, the second line from the bottom there. So no difference. So maybe our paradigm of who should be treated is not correct. And now there's been 2 recent studies that our strategy may be wrong. So the trend to prolong anticoagulant therapy is now cast in doubt by 2 studies, one by Maria de Winter, who did a study with us in Ottawa, and her study showed that for a gain of 1 day in perfect health per person, 99% of patients need to be on extended therapy, and that's over a 5-year period. So you're being subjected to treatment for 1 day, a better life over your 5-year period. And that sounds, to many people, that was kind of crazy, but then Faizan Khan also published a study based on meta-analysis of literature, finding even worse. He says not cost-effective to prolong therapy. In fact, you had less quality of life per person at a cost of $16,000 per person if you prolong therapy in patients with unprovoked VTE. So maybe we're doing this wrong. And these studies were, if you want to look at the specific numbers from Faizan's study, this is what he found. When you compared continuing anticoagulation after initial treatment in a hypothetical cohort of 1,000 patients, indefinite anticoagulation prevented 368 recurrent events and 14 fatal events, but produced an additional 114 major bleeding events, 30 intracranial hemorrhages, and 11 deaths from bleeding. Kind of a wash, and when he factored it in, doing modeling, Markov modeling, all the other complications that can happen and effects on quality of life using these complicated algorithms, he found out that really, as I said, it's not cost effective, and maybe we're doing people a harm. And if you wanted to know the kind of utilities that Maria and Faizan used to check and see if you actually believe this is true, you can see on this slide the utilities for the various events that are in that Markov model, and they all make sense to me. So, for example, if you scan down and you go to an acute intracranial hemorrhage, you see your utility is 0.34, which is pretty crappy. It ranges 0 is death, 1 is perfect health. If you look at your quality of life after intracranial hemorrhage, your utility was 0.71. If you look at your disutility for being on a drug that you just take every day and you don't have to do monitoring on, it's 0.99. So it's really not a big deal to take the drug, but these other factors built into the Markov model suggest that maybe we shouldn't be treating people on an extended basis. So what can we do about this? Well, you can do what's wrong with our paradigm? Well, maybe it's because we're categorizing patients incorrectly. So Maria de Winter, again, did this study where what she did was what's called a latent class analysis. So I don't know if you guys are familiar with this. I certainly don't know how to do it. The math befuddles me. But basically what it is it's a technique that allows phenotypic clustering. So what you do is you take a whole pile of different variables involved for each patient, which can be some of the factors you'll see on here, like age, gender, provoking factors, cancer, comorbidities, anemia, a whole bunch of different factors. You bring all those in, and you classify patients into clusters, and the cluster in which you have the highest probability of belonging to, based on the outcome, is where you end up sitting. So she determined that there were actually 5 clusters that are very different than just our unprovoked and provoked categories. Note that in these 5 clusters, every single one of these clusters will have patients who have unprovoked VTE. So instead of just saying unprovoked VTE is a category and provoked is another, you can have unprovoked or provoked in any one of these categories, but the outcomes in terms of getting recurrent event are extremely different. So these are the first categories, and I'll show you the numbers around in a second. So young men, so it should have been, young men should have been less than 64, but it's 60. Anyway, generally healthy people, you guys missed that joke, I'm sorry. So young men are less than 60, and this 80% were aged less than 60. Young women, 99% were aged less than 60. Generally a first VTE, generally provoked by estrogen therapy, all the way over to the far side, where those who had a history of VTE in the past, 60% of those were men, more of them were over age 60, they had thrombophilia, many of them had unprovoked VTE. So they're just clustered by different variables. And this is what she found in terms of their adjusted hazard ratio for developing recurrent VTE. So the first cluster, the reference cluster is cluster 4. So let's go back. So cluster 4 is the category that most often has patients provoked by surgery, trauma, or immobilization. Because that was felt to be the lowest risk group, she called that basically the reference group. And so in the reference group has no hazard ratio attached to it, that's a 1. And then you look at what is the risk of recurrence according to these other clusters. And you can see that by far the lowest cluster was young women, and that actually does fit with what we know, because I told you that at the beginning, that gender really makes a big difference. And the cluster, actually interestingly, with the highest risk was cluster 3. And the cluster that has most patients who have unprovoked VTE is cluster 5, and that group had an adjusted hazard ratio less than 1. So even though most of those people had unprovoked VTE, it looked like their risk for recurrence, when you take into account all sorts of other variables, is less. So our strategy of adopting a population-wise number, maybe figure, is not correct, because those population figures have not considered all the other variables that patients can have. And so what can we do about that? So, well, Maria has also now developed a thing called the VTE Predict, and you can see the website on there. You can go to it. She developed this through competing risk-adjusted models. She used a number of different studies to develop the model. You can see them on there. There's 15,000 patients to derive and develop the model. It was then validated in 60,000 patients, and at the end, she comes up with a tool that gives you your individual risk for bleeding and your individual risk for clotting based on a number of characteristics, and then allows you to put into the model whether you're on anticoagulation and what dose of anticoagulation you're on, and gives you what your outcomes will be. These were the variables that turned out to be important, and just as you may realize is this case in atrial fibrillation, where your risk for developing a stroke with AFib and your risk of bleeding in AFib, many of those variables overlap. Similarly, variables overlapped here. In terms of validity, face validity for this, you can see that it is actually consistent with some of the previous findings in that estrogen therapy, for example, confers a lower risk of recurrent VTE, as one would expect. Cancer confers a higher risk. History of VTE confers a higher risk. These are the variables that are in the model. All these things listed as predictors. These are the ones that came out. None of them they're all simple, they're easy to get, easy to apply. So let's say you're a 64-year-old male, and you get a PE post-knee replacement. Normal hemoglobin, normal BMI, normal blood pressure, as listed on there. In the past, we would say that's a transient major risk factor. It doesn't require further treatment. But after 3 months, if we say, well, I'm going to put this guy on reduced dose apixaban, let's see what the outcomes will be. In her modeling on this program, the recurrence risk would be 9.2% over 5 years, not less than 1%, as the previous paradigm would suggest. Your reduction would be 7.3% with treatment, so you now have a 2% risk if you're on treatment with reduced dose apixaban for the next 5 years. What is the risk of bleeding? It's 2.2% on no treatment. It goes up to another 0.4% with treatment. So I, as that hypothetical patient, would say to myself, okay, so if I stay on this anticoagulation, I got a 2% risk of clotting versus my 9.2%, and my risk of bleeding has increased 0.4%. Maybe I'll stay on apixaban for the next little while, rather than going off it like the current paradigm suggests. Now, another paradigm which is tossed out perhaps, 55-year-old female, second PE, unprovoked, BP 110, BMI 24, normal hemoglobin. This would be a patient where you'd say, recurrent VTE, no-brainer, on anticoagulation for life. What if we put that person on reduced dose of rivaroxaban? Well, so it turns out that the risk reduction over that 5 years is 9.2%, but the increased risk of bleeding is 5.7%. So, maybe she shouldn't go on the drug. The one caveat about this model is this also includes clinically relevant non-major bleeding, particularly actually important for women because women get a lot of minor bleeding. And so if you wanted to just know the major bleeding rate in her model, you'd take about a third of that bleeding risk. Or you could apply another bleeding tool like the one that we recently published called the CHAPS model, which is also very simple. It's based on basically your age, your creatinine, whether you're on antiplatelet drug, and if you're anemic, or what your hemoglobin is. So that's a pretty easy model to try and get at. So maybe our paradigm is incorrect, and this would be the other weakness of her model is now you can see if you used reduced dose apixaban instead of rivaroxaban, look at how that bleeding risk changed. It went from 5.7% down to 0.4% with apixaban. I think many of us feel apixaban is a safer drug, but probably not that much safer. So because there weren't a lot of people on reduced dose apixaban, her data might be slightly skewed for apixaban and slightly skewed up for rivaroxaban. And that's why you might apply another bleeding risk tool, but this is a superb tool for actually individualizing your recurrence risk. So my recommendation for extended therapy, I think it's time to change the paradigm, or at least relooking at this. Fewer patients should get extended therapy, but we need to consider all VTEs when we make the decision on who gets extended therapy. And other factors are relevant. An individualized prediction versus a population strategy really just has to be better. And if we could apply artificial intelligence techniques to this, it would also be better, I believe, if we could do it in an ongoing way. We need to work on better ways to involve the patients in the decision. Patient preference should always be a strong consideration, particularly if we closely balanced decisions. There's 3 decision analysis modeling studies suggesting patient preference is the most important factor. Unfortunately, we're just not that good at that, but we need to learn how to present unbiased perspective to patients regarding their treatment, including the benefits and harms. And I'm happy to say we have a lot of new thrombosis fellows who are working very hard on answering these questions for us. And unlike my dog, thank you for listening to me today.
Hey, I have a question. This beautiful talk. So I wonder how you, in light of the talk about heavy menstrual bleeding, how much of that difference in non-major bleeding, since we know rivaroxaban and apixaban have very different menstrual bleeding risk, or at least we think we know that.
We think we know that, yeah.
How much of that difference in bleeding risk is really reflecting that menstrual bleeding risk?
Well, it probably does reflect some, but note that the model, the woman I included there was 55 years old. Most women 55 are postmenopausal. So, and the data was derived from, that would be derived from women who were in that age group. So a little bit, but maybe not too much. Yeah.
Thanks, that was very thought-provoking. My question is about your first part of the talk. In that cohort with the about 1,400 patients, if they were not really that sick, why were they getting CTs to find those subsegmental PEs?
Sorry, which cohort?
The one where I think it was a prospective study, 700 patients in each arm.
You mean the study that we did out of Ottawa? This one?
It was the one. So it was one where the high-risk people were excluded. So the cancer patients were out. The I think the acutely ill patients were out. So I'm just wondering where that. This one. This might be the one.
In this study that we did, if this is the one you're talking about, the risk for our cohort study where we didn't treat people. Is that the one you're talking about?
Yes.
Yeah, there was only 296 patients. That's the one.
Yes, I believe so.
Okay, the patients came in with symptoms suggestive of pulmonary embolism.
So they were symptomatic, okay.
Yeah. But you know what, it's also a very good point. So sometimes we see people who come in, we definitely over-image people for suspected PE. Like, it's too easy to do the test these days, right? So sometimes you see people where they come in with left-sided pleuritic chest pain, they do a CT and they've got a subsegmental PE on their right. And you're going like, well, that's obviously not the cause of their symptoms. That's obviously a false positive. So those sorts of people, for example, we would not have even included because I just look at that patient and say, I'm not putting that person in the cohort. They're not getting treated. So if anything, we even moved out people who were super likely to be false positives in that study. So I think we included people more. It was more biased towards including real PEs, if that's getting at your question.
Hi, excellent work. I had a question about the first half of your talk. I believe there were patients that were on antiplatelet therapy and then experienced a recurrent thrombotic event. I'm curious if you looked at the von Willebrand factor levels and if they were abnormally high, or the ADAM-TS13 levels and if they were lower activity than what's considered normal in any of those patients.
Have you done clinical trials before?
No.
Okay. There's no money for doing any of that kind of stuff, okay? So, and it wasn't even part of the hypothesis, right? So I think it's a great idea. You might even have, I'm not sure if you have blood stored, but yeah, you never even get enough money to do the study. Like, so actually doing anything extra is like completely out of the question, unfortunately. So yeah, we didn't look at that.
Thank
but
you.
if I have those samples, I will let you know. Give me your name afterwards.
Okay, sounds good. Thank you.
So Phil, a great talk. it's interesting that the challenges just keep going on and on and on, and very much the same.
Questions never get answered, Ed. It drives me crazy. How many times in my career have I thought we had it figured out, and then you start looking at it and you realize, no, we know less.
So, two questions then. One, undoubtedly, we will see increased sensitivity of particularly radial or imaging studies, which will certainly confound your decision-making even further. And second, how detailed the studies have been done on really aging people, such as 70 to 80, 80 to 90, and then undoubtedly 90 to 100, which will considerably impact your decision-making too.
Yeah, let's face it, in most trials, we don't have super elderly. This is the other problem with all of the data, and even the data that drove the paradigm of provoked versus unprovoked, is the patients most of those patients came from randomized trials, and although everyone says randomized trials are the best level of evidence for medicine, there's a lot of serious limitations for randomized trials, because you often don't enter the patients in who you're going to see in your practice. They're very selected. They're selected in terms of their willingness to be part of a trial. They're often selective in terms of their health, their access to care. So certainly elderly people are the exception. You look at the mean age of patients in all of our studies, it's like 55. But if you look at the risk of getting a VTE, it's like flat until you're over 65, and then it goes like this. So the mean age of patients in our studies really should be 75, but it's 55. So definitely there's a gap there in terms of what we know about how to manage elderly people, not to mention race. So 95% of all the patients from all this data and all these randomized trials comes from white people. So and there's lots of data that disease is quite different in other races. Yeah.
Anybody else? I'm sure there's one. Yep, there you go. The guy over there.
So these subsegmental PEs, where are they coming from?
Great question. So we presume they come from the legs. This is the other paradigm we have in the world of venous thrombosis, is that clots in your lung predominantly come from your legs. And there's evidence to suggest that's probably true, but we don't know that for a fact. So if you look at the leg and there's nothing there, where did it come from? It could have come from there's not a lot of places it can come from. It could come from an arm DVT. It could come from your legs.
Do you think that it's possible at times, if you have a lot of microvascular clotting, that you can get something big enough to occlude a subsegmental artery?
Yep, I do. And in fact, what I've seen is, I think you can get, if you want to call it, it's not a pulmonary emboli, it's a pulmonary thrombosis. And I've definitely seen people have pneumonia. They come in with pneumonia, fever, green spit, and they get a CT scan. You're like, they have pneumonia. Why do you do a CT scan? And then you see a clot in the vessel leading to their pneumonia. So inflammatory changes there, to me, clearly have led to that clot. And I treat those as not a pulmonary embolism, but as an in situ thrombosis. But how often does that happen? No clue. But there must be some of that, right?
Okay, good.
Great, thank you.